Good morning, everyone, and welcome to one more lecture of hematology. In this lecture, we are going to start with um, lymphoid lymphoid malignancies. Okay, so in lymphoid malignancies, one of the very important topic is acute lymphoblastic leukemia, and like I'm sure, like until now, you had an idea what is myeloblastic lineage and what is lymphoblastic or lymphoid lineage. So this is the first malignancy which we are going to study, which belongs to lymphoid lineage malignancy, and this one is acute lymphoblastic leukemia or ALL. The important thing in this one is what um, it is acute, it is lymphoid lineage or lymphoblastic, and it is leukemia or when it is blastic. So what it means, like there will be too much blast cells. Okay, uh, by definition, it is a malignant disease of the bone marrow in which early lymphoid precursors proliferate and replace the normal hemopoietic cells of the marrow. So what's going on is that the immature cells of lymphoid precursor cells, again I will show you the same mm, photograph like this one. We are discussing this lineage, or you can say this lineage right now. Okay, so the early precursor cells, these one, they are going to proliferate, they are going to infiltrate the bone marrow. Okay, and we call it as ALL, acute lymphoblastic leukemia. So again, WHO divides ALL or acute lymphoblastic leukemia into two types depending on the origin of the cells. Now myeloid lineage is a big lineage, you can say. Myeloid lineage give rise to platelets, it give rise to red blood cells, it give rise to neutrophils, basophils, eosinophils, but the lymphoid lineage, it give rise to B cells and T cells. So uh, B cell and T cell, or B cell precursor B lymphocytes, lymphoblastic leukemia, or T cell precursor T lymphoblastic leukemia. And again, one more classification, that is called as the FAB classification, or French American British classification. They divide, like they classify into L1, L2, L3, but it is like no longer used. So WHO classification is the one which is used most of the time. Okay, now the most important thing to remember is uh, 70, like this one, acute lymphoblastic leukemia is most common in children. Okay, less than 6 years of age, less than 6 years of age. Okay, 70% or more than 70, like you can say around 75% of the times it is in this age group, and the rest of the 20% of the 25% of the patient, they appear in around the age of 40. So you can say this is again a condition which have a bimodal type of presentation. You can say uh, the cases appear uh, in like either less than 6 years of life, and then there is one more peak. 25% of the cases, they appear when the patient is like more than 40 years of age. Okay. Uh, okay. So if we will talk about the clinical features, uh, like most of the clinical features, they will remain same. Like again, I spend a lot of time, in the start just to make you remember, like what will happen. Here, there are typical features are written, guys, but you could say most of the clinical features, they will be same, like what we had done before. For example, there will be anemia, there will be uh, thrombocytopenia, there will be uh, thrombocytopenia, okay, as well as there will be same thing, infections, okay. Like these features will remain same. Why? Because even if it is lymphoid lineage, remember that the cells are over proliferating. The abnormal cells are, when the abnormal cells are over proliferating, so what they will be doing, like they are going to exhaust, or they are going to use up all the material which is needed to make the other cells. So that's the reason, like most of the features they will remain same. What are the features of acute myeloid leukemia? uh, you can say, okay, bony tenderness will be present in this one as well. Why? Because the cells are formed in the bone marrow, right? So bony tenderness will be present, and anemia, thrombocytopenia, infections will be present. Organ infiltration can occur. The same things can occur. The organ infiltration, like I gave you the example of skin, I gave you the examples of gingiva, I gave you the examples of spleen, liver, all the structures. Leukostasis or hyper leukocytosis syndrome can occur. Metabolic syndromes can occur. Like most of the features will remain same. Like the features of what you can say, what I discussed in detail in acute myeloid leukemia, right? But there will be, of course, some of the differences which will be present in these one. For example, what is going to occur is this thing is like again the same thing, okay. The infection of oropharynx, lungs, perianal region, thrombocytopenia, and all this stuff. Organ infiltration will remain same. There will be tender bones, lymphadenopathy, hepatosplenomegaly, meningeal signs, headache, nausea, vomiting, visual symptoms, especially in ALL relapse. Okay, so all these features are more or less like what is we have already covered and what we already understand why these features are there. So how we investigate? Of course, we will go for CBC. We will found that the leukocytes will be increased. Okay, and there will be neutropenia, anemia, and thrombocytopenia. May have increased uric acid, potassium, phosphate, calcium, and LDH. Like again, you know why? Because of that tumor lysis syndrome. Um, DIC, disseminated intravascular coagulation. We can do all these investigations. Then there is leukemic lymphoblast, which lack specific morphology, like they have no granules or cytochemical features, therefore diagnosis depending on immunophenotyping. Like the same thing, how we diagnose is simply we check the cell type, immunotyping, and all those things. 25% of the patients who have ALL, they have Philadelphia chromosomes, which is, ABL, BCR, ABL genes, like tyrosine kinase inhibitors. Chest X-ray can be done because the patients with ALL may have a mediastinal mass and lumbar puncture prior to systemic chemotherapy to assess the CNS involvement. Okay, this thing. But one of the thing, guys, before performing lumbar puncture, make sure these tests are normal. Okay, the clotting profile should be normal, because lumbar puncture may be like if it is performed in someone who have increased chances of bleeding. So what can happen? Like they will start bleeding, and the bleeding will be hard to stop. Okay, so uh, the treatment strategy is somehow same, but there is like some more steps, like induction is there, and consolidation is there, which is same like AML. In this one, we have to add two more things. One is maintenance chemotherapy and one is prophylaxis. For example, the CNS involvement is not so common in AML, so that's why CLL do involve the CNS, right? So we do prophylactic CNS radiation, okay, to protect them. And in AML, there is no benefits of doing, you can say, the maintenance therapy, okay, in AML. So that's why in ALL, we do go for maintenance therapy as well. So the treatment have the same aim: eliminate the abnormal clone or abnormal cells, right? So induction chemotherapy is to induce induction, induce like complete is to induce complete remission, and where they keep on doing that until there is undetectable leukemic blast cells, and to restore normal hematopoiesis. And consolidation is or intensification in chemotherapy. What is that? Like consolidation is simply continuing same chemotherapy to eliminate subclinical leukemic cells, and intensification is a high dose of different chemotherapy drugs to eliminate cells with resistance to primary treatment. So, see, consolidation and intensification are all consolidation and induction and consolidation are same like uh, AML, right? But consolidation, like the consolidation phase is keep on giving the chemotherapy to make sure like all the leukemic cells are destroyed, and intensification is to use some other drug to eliminate all the cells which are resistant to the primary treatment which we are using over here. Maintenance therapy is like low dose chemotherapy over prolonged 2 to 3 years, like for the patient, so that there should be no relapse. Relapse is what like the disease should not appear again, right? And prophylaxis is for CNS. So either we can give methotrexate or CNS radiations can be done intrathecal, like directly into the CNS space, or systemic can be done. Okay, wait. Yes. Of course, like hemopoietic stem cell transplantation. Of course, like this is a treatment for all the blood cancers, anyways, right? Simply, they are potentially curative due to pre-implant myeloablative chemoradiation and post-implant graft versus leukemic effect, but relapse rates are non-relapse mortality is high. So, like remember, stem cell transplantation is a treatment for almost all the type of leukemias, because we are going to give them a new stem cell, a new bone marrow simply. So the prognosis depends on response on to initial induction. Uh, Good prognostic factors you can see like young patients, WPC is less, T cell phenotype, like when there is T cell type, not B cell type, when there is absence of Philadelphia chromosome, and early attainment of complete remission. So Philadelphia, just write it completely. So childhood ALL, uh, 80% have long-term remission. Okay, high cure rates in children because of better chemotherapy tolerance, and low prevalence of BCR-ABL fusion gene. Because in children, there is less chances of having Philadelphia chromosome. And in adult ALL, 30 to 40% is 5 year survival. So of course, like the disease is not so uh, good. The prognosis is not so reassuring. This is a table which is showing the differences between the AML and ALL. Okay. Uh, Remember, how to remember like which condition occur in which patients is. Remember small SMALL. So ALL small. The last three letters are ALL. So ALL occurs in small people, right? So AML, of course, it occurs in big people. So AML in big people, ALL in small people or kids. Acute myeloid leukemia, remember, macrocytic anemia, I told you, is associated with AML. So big blast, and in ALL, there is small blast. AML, the mortality rate is high, and ALL, the mortality rate is small, SMALL, small. AML, the cells have a lot of cytoplasm, they have less cytoplasm. ALL, of course, like they are big, so more cytoplasm. They are small, so less cytoplasm. And when they are big, they have a lot of nuclei. When they are small, they have less nuclei. Remember, I told you about AML iron rods, okay? In ALL, there is no granules. These are the stains which we use to stain the cells of AML, and these are the stains we use to stain the cells of ALL. And maturation defect beyond myeloblast and or pro-myelocyte, and there is maturation defect beyond lymphoblast. Like these are the name of the cells, like the premature cells. There are different stages. Of course, like you guys have done this thing in physiology, how the cells they are like formed and what are the different stages of erythropoiesis. Okay, so before going to CLL, I think I will go in the same routine, by the way, which I show you over here. Okay, but we can do CLL, by the way, because one of the classification, which I wrote over here is like leukemia, we will do this, then we'll go for lymphoma, then we will go for plasma cell dyscrasias, right? So now what you can say, CLL, chronic lymphocytic leukemia. Again, this one is a clonal malignancy of mature B cells, right? And it is most common leukemia in Western world. Very important point to remember. Okay. Most common leukemia in Western world is which type? CLL. Which means like if you're going to see any patient in your life which is old, maybe it will be a patient of CLL. Male are more commonly affected by other than female, and again it is a disease of old age. Pathophysiology is accumulation of neoplastic lymphocytes in blood, bone marrow, lymph nodes, and spleen. Okay, so the lymphocytes are abnormal cells, okay, like neoplastic. So again, see, 25% are asymptomatic, so it's an incidental finding. So like maybe they will go for a CBC, and on CBC the results will come back as high number of lymphocytes, and then of course they will run for the investigation. So that's how they get diagnosed. 5 to 10% with B symptoms. Now these B symptoms are very important, and these B symptoms, like this is the first thing which we are studying in which there is this B symptoms, right? And now what is this B symptoms? Unintentional weight loss of body weight within previous 6 months, temperature greater than 38 degrees centigrade, or night sweats for basically 2 weeks or greater than 2 weeks, right? Without evidence of infection, and extreme fatigue. Okay, so uh, number one is unintentional weight loss of greater than 10% within the last 6 months. Unintentional weight loss is simply like this, that um, when there is no change in the lifestyle. For example, someone who is not doing any exercise, he have not undergone any surgery or anything like this, in the past 6 months. So more than 10% weight. Okay, the unintentional loss of body weight. Remember, it is greater than 10%, right? So, for example, someone who is weighing 70 and in 6 months he is losing 7 kilograms out of that. Okay, his weight is like 63 or less than that. So it means like, and he have not changed any routine of his life, so it will be considered as unintentional weight loss. Or the second feature is night sweats. Okay. The third feature is temperature greater than 38 degrees centigrade. The fourth feature is extreme fatigue. So the thing is, anyone who have, see, these are four features. Okay, I talk about the four features. One is about weight, one is about temperature, one is about night sweats, and one is about extreme fatigue. Anyone who have one or more than one feature, it means like the B symptoms are present. Okay, so it's not like this that we look for all these four things in the patient. Rather, if anyone have even in one thing out of them, it means that like the B symptoms are present, right? So now, guys, see, uh, these patients or all the conditions which you are going to study now, especially lymphomas, you will found that they have more lymphadenopathy, splenomegaly, and hepatomegaly. Okay, or you can say uh, the secondary lymphoid tissues become enlarged. Okay, so they have immunity dysregulation as well. So they have autoimmune hemolytic anemia, Coombs positive. Again, I explained this thing before. They may have immune thrombocytopenic purpura. They may have hypogammaglobulinemia plus minus neutropenia. And bone marrow failure is a late finding secondary to marrow involvement, like marrow involvement by C, or like you can say marrow occupation by CLL cells. Of course, like when the bone marrow is completely infiltrated by the cells. So what will happen? Like, of course, they are going to like fail, and they are going to they will present with the bone marrow failure. No other cells will be formed. Okay, so remember these B symptoms, very important. So what are the investigations? Again, CBC, absolute lymphocytosis. You will found like the lymphocytes count will be raised. Then we will go for peripheral blood film. We'll found like lymphocytes are small and mature, and there will be smudge cells. Okay, what is smudge cells? Again, I would write it over here. They are basically damaged lymphocytes. Okay, smudge cells are damaged lymphocytes. Okay, so these are called as smudge cells. Uh, we can do flow cytometry. Okay, and I don't know how many of you know about flow cytometry, but flow cytometry is a very important, you can say, have a lot of usage, what you can say, in identifying what kind of cells are they, okay? Or you can say the characteristics, like what kind of tags are there on the cell. For example, if we will do flow cytometry, we'll found that they are CD5 positive or CD20 positive or CD23 positive, right? Sorry, 23 positive. So the important thing over here, flow cytometry is basically, again, you can see a YouTube video on that. This is of course, it's a lab test, to identify the characteristic of certain cell. Okay, so what they do, by the way, uh, what they do, like they let the cells pass through a laser beam. Okay, and when the laser fall on different cells, the laser is reflected uh, in different fashions depending on the makeup of the cell. Okay, so like every cell has its own characteristic, you can say, to reflect the laser, or reflect the light. So this is how they identify, they name different cells, right? Of course, like these are special devices or sophisticated devices which are available. So that is called as flow cytometry. Okay, So sometimes they label the cells as well, okay, for immunotyping. So this is after labeling CD5, CD25, and all these things, okay. All these things can be seen. So flow cytometry can be done, cytogenetics can be done, and again, like I think I already explained you when I was teaching you genetics, okay. What you can say in what you can say in when I was teaching you that Down syndrome, right? I teach you, what is fish technique, okay. So and like this fish technique is fluorescence, fluorescence in situ hybridization. Again, it's a technique, which can detect chromosomal abnormalities, and that's why I teach you this thing in what you can say in Down syndrome, and I was teaching you Down syndrome. So fish technique or fluorescence in situ hybridization technique can detect, you can say, chromosomal abnormalities, okay. Of course, like simply to this one basically can detect even the smallest abnormalities like micro deletion, okay. Like if the deleted part is very 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 small, so this fish thing can the fish technique can catch these things. So fish studies can be done, and we can check the bone marrow aspirate. So lymphocytes will form more than 30% of all nucleated cells will be there, and infiltration of the marrow by lymphocytes in four patterns can be seen: nodular, interstitial, diffuse, or mixed, okay. And that's how they label the patient, like what type of CLL the patient is having. Either it's nodular type, either it's interstitial type, diffuse type, or mixed type, right? So natural history. CLL, I'm sorry, CLL is a very very slowly progressive disease, right? It does like it's a chronic type of leukemia, right? So it goes slow, the progression is very slow, okay, but it is incurable as well, okay. Very small amount of patient, they present with aggressive disease. It's not like this that of course all the patients they show the slow type of disease. Rather, there are patients in which like they can show some aggressive type of disease as well. So and though that minority of the people who show, I'm talking about this aggressive disease usually associated with other chromosomal abnormalities like P53 deletion, right? So guys, first line therapy, uh, like of course we check the cytogenetics and decide on various things, okay. If the patient is stable, so this observation is needed, okay. If he's in asymptomatic, he's stable, or he's in early conditions, just this thing is done. Uh, if the patient is not stable and you decided to treat them, then first line drug most of the time they give is uh, rituximab, okay. This was the most of the time the first line drug. They are considered as a first line drug, okay. Rituximab, and there is one more, uh, obinutuzumab, okay. So these are considered as the first line drugs. So this can be used. Fludarabine can be used. Cyclophosphamide can be used. Cyclophosphamide is not written over here. That can also be used. Okay, a combination of the drugs can be used, like fludarabine with cyclophosphamide with rituximab. Okay, so these combinations can be used as well. Chlorambucil can be combined with obinutuzumab. These drugs. Okay, they can be combined together, especially in elderly people. Okay. And corticosteroids can be used as well in these patients, okay? And of course, radiotherapy can be done as well. So nowadays, by the way, there are certain new drugs, by the way, guys. Uh, I don't know, like I must tell you those drugs or not, but okay, like just for a record, like uh, you can write it down, but of course, like hard to remember. They are called as molecular therapies. Molecular therapies, okay. And what is those are basically one of the name of the drug is called as I remember Idela, Idela Lysip, okay, and ibrutinib, okay, tinib. This one. These are the name of the drugs. Like these are newer drugs, of course. Uh, I'm sure, like maybe they are not written even in like lipid or pharmacology, maybe. So the prognosis is predicted by a staging system. You can say the median survival I can write over here is around, you can say 9 years. 9 years is the survival, median survival, okay, for these patients. But of course, like it varies from person to person. So there are low risk people in which what you can say just lymphocytosis and blood and bone marrow is only there. There is intermediate risk people and there are high risk people in which like lymphocytosis with disease related anemia or thrombocytopenia is there, which means like all of the bone marrow is involved, right? So this thing is there. Complications, again, bone marrow failure, immune complications can be there, like autoimmune hemolytic anemia, immune thrombocytopenic purpura, immune deficiency, polyclonal or monoclonal gammopathy, often IgM type, hyperuricemia with treatment. Okay, so many of these things are present. So 5% undergo Richard's transformation. What is Richard transformation? It is like aggressive transformation to diffuse large B cell lymphoma. Okay, large B cell lymphoma. This is the same thing. So, like this is like Richard transformation. Many of these people they can go in this one. So that's all about what you can say CLL or chronic lymphocytic leukemia. So um, our next topic should be lymphomas. Okay. I was planning to start a new lecture, but okay, I will do a new lecture for that.